This is Dr. Tiwari.
And this is Dr. Kocak.
And you're listening to the
Best Podcast Ever.
Broadcasting from Columbus, Ohio, we'll be talking about plastic surgery procedures focusing on only the breast.
Ranging from breast reconstruction to breast enhancement and reduction, we'll cover everything you ever wanted to know about the breast. Welcome to the Best Podcast Ever. This is Dr. Kocak, and I'm here with
Dr. Tiwari.
Yeah, we got the usual crew. We're really excited actually today to have Lindsey Byrne with us, and she is probably one of the brightest and most well-informed genetic counselors we've ever had the pleasure of working with. So we're really excited that she's taking the time to come on our podcast today. And I have a feeling that both Dr. Tiwari and I, along with our listeners, are going to learn a lot of useful information. So without further ado, I'll let Lindsey introduce herself and tell us a little bit about her background.
Hi, guys. Thank you so much for having me. This is really fun, and it's good to see you guys and catch up since I know we've worked together through, I couldn't even remember how long it's been since I've known you guys, but...
Right, at least 6 years, because we met when we first left Ohio State, but it was pretty much soon after that, because we first worked with you at Ohio Health, I think.
Yeah, so I mean, it feels full circle. Like I keep hopping different places where you guys are when you're not. But yeah, so this is great to be. I think genetics, as you guys know, is so hugely important in regards to care for breast cases and especially breast cancer cases. So I've been around for over 10 years at least. So I think it's been about 12 years. I've lived in Columbus my entire career, but before I came here to start working, I went to Sarah Lawrence in New York to get my master's. So being a genetic counselor is a master's specific degree. So we learn everything genetics and specialize then after there. So once I left there, I decided I wanted to do cancer, and I worked at Ohio Health for 8 years. And I saw cancer patients there, all sorts of cancer patients. I actually started a cardiovascular genetics clinic there as well. I had a passion side gig in wanting to do cardiac genetics as well. Like I had done my thesis on that. And then I took a job at Mount Carmel, in 2015 to take a leadership role there and to start their program and get it up and running a little bit more smoothly and consistently. And so I worked there in cancer and again, worked a little bit in cardiac genetics there for a bit. And then more recently, I've been at The Ohio State University since the fall of 2018. I took that specific role for a lot of different reasons. I started the GU specific genetic counseling program there. So prostate cancer has become kind of a bigger cancer in the last couple of years with NCCN guidelines. And so we really needed to start seeing those patients and seeing kidney cancer and bladder cancer patients. So I started that clinic. So I was hired to do that. And I also wanted to dabble in some research. So as genetic counselors, we sort of are part of research, but there are more specific roles. And so at OSU, I'm 50% research. So I will be doing more research than I probably have ever done. And I also work with the grad students and I teach a class. So I wanted to get it more involved in some other aspects versus just being more clinical. So I've been kind of all over the city, but I'm still live in the same house, just different hospitals.
Well, it's one thing we have in common then, because you know very well that we've also been pretty much in every system at some point in our careers as well. So that definitely is something we have in common. You know, it's interesting. So for some of our listeners, and I think also for, us, I think it's important to understand that caring for patients with breast cancer or high risk situations, which we'll talk about more, I think sometimes it's hard for people to understand how many different players there are in that care. And can you tell us a little bit about how sort of the genetic counselor fits into the picture in what they do and what role you have in caring for these breast cancer and potentially breast cancer patients?
Yeah, I think we are really important in the cancer team as such as we have that extra time that I know that you guys as physicians and other specialists just don't have to let them take a moment and talk about their family history and answer questions, because what I find the most with female breast cancer patients is, what does this mean for my kids? What am I going to do? And even though they're literally going through a diagnosis, there is such anxiety about what this means for their family members and their kids. And so that's where the genetics piece can be really helpful to help with family members as well as their own information. But we can provide that piece that can provide them information to give risk for the family members as well as extended family members. So we have that ability to take we usually spend about 45 minutes to go through all these questions that no one else has had the time to go through because we specialize in that genetics and the genes piece of the puzzle. And the best part about that is it can really provide you guys information as to say, well, what kind of surgery would we may do if we do find some type of hereditary finding? The patient may change their surgery completely or their treatment completely, or change their care down the road for other cancers as well.
So who, Lindsey, are the type of people that need genetic counseling when it comes to breast cancer? Who are the people that you see?
Yeah, so the biggest influx of who we see right now or are diagnosed right now. So those are individuals. The beauty of where our field has moved from when I first started, we couldn't get test results quick enough for patients to be able to decide on surgery and treatment right away. But we have that ability now, that the turnaround time, and we can get the result fast enough to where we can provide them that result to where they can then say, should I decide to have both breasts removed versus just treat this cancer if I had a hereditary finding found? So we would be looking at anybody who's young. So I would say 50 and younger. And then if there's triple negative breast cancer, 60 and under, and or if there's somebody who's a bit older than those ages but has family history or has Ashkenazi Jewish ancestry.
We hear family history a lot. Like a lot of people worry that they have a strong family history, but like, what is the definition of family history?
I think that is a really great question and really hard to tease out, because in order for a family history to get to me, that means that someone has to take that time to take it too, right? And a lot of times there'll be patients that I just don't even know my family history. So I am not of one that says you cannot have a genetic counseling appointment if you don't know your family history or if it's unknown. So that's where I encourage providers to refer to genetic counselors if a patient's interested. It's really not just about the testing. It's just about the education of understanding the process of what genetics is, what genetic testing can mean to them. And you guys probably know that the American Society of Breast Surgeons actually released a statement last year suggesting that all women be offered genetic counseling, genetic testing if they have breast cancer, which puts out a whole new thought process. So should everybody who has breast cancer have genetic testing? And I don't know how you guys feel about that, but for me, this is my opinion and not any hospital I've worked for opinion. I think I agree with that statement. I think all women who've had breast cancer should have that discussion, and then they can decide if it's cost effective for them and if it makes sense, whether insurance will pick up that cost or not. So I think it's really hard to define family history other than having a couple of relatives, so at least two relatives with breast cancer, or if one other relative had a young breast cancer, or if there's, say, like an ovarian cancer or a pancreatic cancer or a unique cancer like male breast cancer. So there's really this huge schematic. So I find it challenging to decide who should get referred based off family history unless you're really up on that, or you have your list of NCCN criteria next to you to say, okay, well, they have all these features, then I should send them.
So in your opinion, a broader sort of perspective for genetic counseling makes sense, and even more sense than in the past because we can get testing so quickly.
I agree with that. I think most patients want that information, and if it's going to cost them a couple $100, they're okay with that. So I think what's happening now is breast surgeons are saying, hey, there's an option for this. If this is something you want, they then refer them, and then we as the genetic counselor talk through the ins and outs of that. And cost when I started in this field for genetic testing was about $4,000 to $5,000 without insurance coverage. And now if you wanted to pay out of pocket, you could get testing for $250. So
wow.
Yeah. And so, yes, that's not $50. And so that can still cause some cost issues for people. But I think that's a big myth that people think that cost is extremely high. And so when it's $250, why shouldn't we be discussing, the pros and cons of that and what that could mean for a patient and their care?
Have some of these more widely available sort of like 23andMe type things, the lower cost tests, brought a change to your field at all?
So 23andMe is a bit different than what I typically do. So that's more looking at what we consider SNP testing, or very small pieces of genetic material, versus looking at germline testing. And so I think the biggest piece, this will give a little historical background, biggest thing that changed genetic testing was when the patent was released on BRCA1 and 2. So there's a testing company, and it was back in 2013. Myri Genetics finally lost the patent in the summer of 2013. And then what happened was they were charging the $4,000 to $5,000 just to do those two genes, and no other testing company was able to test for those. So once that patent went wide, all companies were able to then incorporate BRCA1 and 2 testing into their panels, and then testing dropped immediately. So it went from the $4,000 to $5,000, and then it started going to I think it was $2,000, and it just kept decreasing because then technology changed and it got faster. So it was really the change of the patent that started where the cost went down, and then because more companies, then you have more competition, and then technology changed so things could be faster, and that also changed that. 23andMe is a whole nother ballgame in regards to testing because that's more direct to consumer, and there are genetic counselors that work at the company, but you're not getting face-to-face counseling. It's a patient ordering that type of testing online, and the results aren't completely full. You can get a couple of the mutations from BRCA1 and 2, but it's not full BRCA testing. So if you were worried about breast cancer risk, you would want to see a genetic counselor to do full BRCA testing. Does that make sense?
But with those being widely available and used and, being given as Christmas gifts and stuff, did you guys see a rise in the number of genetic mutations that were being discovered? I mean, did it increase the rate of finding high risk situations?
Does 23andMe increase?
Yeah, like Ancestry and 23andMe. I mean, those things are so widely used. You think that it's going to bring to the surface a lot more genetic mutations that weren't otherwise going to be detected.
So 23andMe, what we're seeing from that perspective is more people are reaching out to us to talk through some of those types of results. And every once in a while, so there's a strong emphasis on wanting to know Jewish ancestry because people who have Jewish ancestry have a higher risk, not only from a cancer perspective, but they also have higher risk for conditions that we test for more prenatally for childhood onset conditions. So we've actually seen an uptake in people coming in saying that they have a 1% Jewish ancestry or 2%. It's what do you do with that? That's so small. But do you start offering testing because now people are worried about Jewish ancestry? And I think we as a specialty haven't quite decided. And I think it's on a case by case, what you explain, what we know about that, and to the patient that's a very small percentage of Jewish ancestry. But if you want to do the testing, you can do it that way. So things like that are definitely coming up and a lot of people are coming to me to talk about, I think a bigger thing that's coming out of 23andMe testing is people are then taking their raw data and uploading it into databases, which I'm not going to say I'm for that for sure, because it can cause a lot of issues because those databases aren't secure and they can read out wrong results. And so I do have people coming to me and saying, I have a BRCA2 based off of these results that were uploaded. And I then run it by the labs that I use and that I trust. And, a lot of times it's not legit and it's not true. And people are then running those on their kids, which is also not so good. I'm not sure I agree with that either. But these are the stories that you're probably seeing in the media, that people are getting major heart surgeries because they had 23andMe testing and it wasn't validated. And if it's not validated from, doing it from an uploaded database thing, it could be completely a wrong result. And so trying to explain what that means. So we're getting involved in different areas outside of our kind of standard, but the more that people test, the more unknown results that we can classify too. So that's been really helpful. The more that people hear about genetic testing, the more ethnicities that we test, the more the unknown results that we come up with, the more we can clarify those and look at different populations that are Asian and African American. We can learn more about those populations, the more genetic testing that's done too.
One of the interesting things that I've seen over at least our careers, and we've been in it for a little while now, is when we first started, like you said, they really weren't testing for a lot of stuff. They were testing for a couple of genes. And I feel like that profile gets bigger and bigger every year. And we start to hear about genes that I feel like just new ones keep popping up.
Yeah, I mean, we had never even heard of the CHEK2 mutation, the PALB2 mutation until maybe 3 years ago. And now it's not uncommon for us to see patients in our office who come in with these genetic mutations. So not only are there new mutations that are, ones that we're not aware of, but do we know what to do with some of these new mutations? Do we know the prognostic implications?
I think that's what is really tricky. It's the balance of we're learning so quickly that genes may have something to do with, say, perhaps breast cancer or other cancers. And we want to test for, and we want to give patients every single thing that we can test for, but then how useful are some of these genes? And I will admit I'm one that will offer whatever the patient wants to do and how much, because let's say that they have this test result from 2018. If they never test again, the information we learn about those genes could completely change in 15 years. So it could be a baseline, and then we learn more about it. So, for example, CHEK2 has been around for a long time, but we know immensely more about it in the last 5 years, like you just said, than we did when we first started seeing it hit, a while back. And I think that's the goal, is that we in genetics want to put these genes out there to physicians and genetic counselors and geneticists and all of us in the community to say, hey, we're starting to see this be associated. Maybe this can provide some relief, some data, but we can't say like, hey, you should have your other breast removed because maybe there's second breast cancer risk, or let's start removing ovaries and such, because a lot of some of the newer genes that we're learning about, we just don't have solid data to give that. With PALB2 and CHEK2, we've learned enough that they definitely have risk for primary cancers, but we're still in this bit of gray zone for second breast cancers, but we are seeing them. So then it's like, how do you manage that? It's so different from BRCA1 and 2, where we know that there's a clear higher risk of second cancer. I think the way that I describe it to patients is, I'm in this with you, and as we learn more, I will let you know, and it can maybe evolve, and you're just going to have to go with what feels good to you in regards to treatment based off the little bit that I know. And usually patients are pretty comfortable with making a decision once, they've talked to me, we've talked to the breast surgeon, plastics, all of that, and trying to figure out what's the plan and what's the next step.
Yeah, good example. We had a patient not too long ago who had undergone breast cancer surgery and reconstruction, and then her daughter was found to have a genetic mutation. So this lady was tested, now found to have genetic mutation, having already been through a reconstruction. So I think those types of more complicated scenarios we're seeing more and more as we're trying to figure out how to incorporate some of these genetic testing results. Another really tough area that I've always kind of wondered that you guys have to deal with is, how do you talk to family members, some of whom may not want to know that they've had a family member who's been tested and is positive for a BRCA or CHEK2 or other type of mutation? How do you navigate that?
So a lot of that has to depend on a little bit of the patient first, so your primary person. And so I can't force them to tell their family, and that can feel really uncomfortable, So what I do try to work around, if they don't feel comfortable telling their family members, is I tell them that I will draft up a letter they can just mail to them, or if they want us to work through that, and so they have as little hands-on if there's relatives they're not as close with anymore. But sometimes people just don't know where their families live anymore. And as a provider, just kind of have to accept that, okay, well, I will tell you, and we will tell your kids and figure that out. But there's nothing I can do about those first cousins and such, unless the patient wants to help me and we can work together to help navigate that system. So there isn't a straightforward answer. I think all of us as genetic counselors try to navigate the best we can so we can help those family members, but we need the patient to help us too, because I can't just call up a patient's family member, because that's against HIPAA, right? So we also have all these rules too to try to navigate and follow. So that is a really tough situation. And I think also the conversation with parents about when to test their children and how young and how old. And, I have a lot more of those types of conversations about how do we navigate that piece.
What's the answer to that? How young is too young?
And I think that depends on the syndrome. So, for example, if it's something like BRCA1 and 2, which, is our most common, and we talk about that in the media the most, those, I usually say we start testing once they're 18 or they're of adult age, but really then talking through what would change at 18. So nothing would change at 18, but really for women, it would be 25 where we would start implementing any high risk interventions for breast. So I tell parents about their kids, start talking about this with them between age 18 and 25. We want to make sure we test them before any changes would be implemented. And I also say that we would probably want to talk about testing before they would have kids, in case they would want that information before they would have children. So between talking through that piece and then talking about life insurance are the two big things that I try to get through, in discussions with parents about when to test younger family members. Life insurance, as you guys know, we don't have any protection against, there are laws that protect our patients against being discriminated against health insurance and their employer or employment, but there isn't any laws against life insurance. So I always try to have that conversation with young, healthy individuals to say, maybe we should look at getting life insurance before we do any genetic testing, because we don't want to give you any disadvantage in regards to long-term life insurance. And so we talk through a little bit of that. So between those two things about when do actual high-risk recommendations start and life insurance, I should come up with a plan with parents as to when it makes sense to start having conversations to test.
We've never thought of that.
That's a horrible thing to have to, think about, life insurance when you're in your 20s. I mean, that's so much to deal with. I feel your heart goes out for people having to deal with that.
Yeah. And I think you guys probably deal with the more gut reaction from younger folks who test positive, that they just want to have both breasts removed right away versus like maybe processing it a little bit. But I think you probably know as well as I do, they've watched their parents go through chemo and radiation and they just decide, I don't want to go through that. But you guys probably have the more difficult conversation of like what it actually means to have that kind of surgery versus like, I'm just getting rid of my cancer risk, So I think there is this balance that you guys probably deal with versus just the genetic piece of the surgery aspect.
Yeah, I think that it differs. I think it's much harder for younger patients. I think it's hard for anybody, but it's really difficult on the young patients, who may have never had a surgery before, and this is, a life-altering event, obviously. But do you have a sense of the patients that you talk to? What percent go on to prophylactic surgery versus surveillance in a high-risk clinic?
So are we talking somebody who's completely unaffected or someone who already has a first breast cancer?
Unaffected.
Yeah, unaffected.
Okay, because I would say the affected people always get the prophylactic pretty much almost all the time. That's a great question. I think the majority of my patients tend to want to do the prophylactic, but sometimes they take a little bit of time. So depending on their age range. So if they're in their 20s, sometimes they'll go have conversations with you guys and then maybe plan for like early 30s or such. I find it a little bit more rare to do screening for a long period of time. And you guys may have that data better than me, because once you guys have a conversation, I don't know if they then change their mind. Like, do they decide to not do it as frequently or decide, yeah, I'm going to go ahead and have this surgery done?
I mean, I think patients really find the screening a little bit anxiety provoking, because every 6 months you're waiting on that result. And it's why I think ultimately, patients come for a prophylactic surgery. But, we've kind of touched on this before. We're seeing more and more patients who are diagnosed young and say, listen, I want to come in 18 months or 2 years for risk reduction surgery in the summer, and really kind of plan it out that way. And that's a whole different type of patient. And they come in very, very well educated. Do you feel that the people that you're seeing now are educated about genetic counseling, or is this a new area for them, as it is for all of us?
I think I get still a little bit mixed. So I think my breast patients tend to be the most educated in regards to this. And I think, the internet, it just, things are everywhere, and genetic counseling is more known than it has been in the past.
Would you say that the Angelina Jolie occurrence probably changed the awareness? And I mean, in our field, it was a humongous difference. How did it impact your guys' situation?
I feel like it's that moment in my career that I won't forget that day ever, because I literally had a text that morning that the news was at my office to interview me, and I didn't even know what had happened yet. So,
I had a feeling.
It was crazy. We had even 90-year-olds calling saying they needed to test. I'm not kidding. It changed the world in regards to how breast cancer and genetics happened, and the fear, and everybody needed to do it. And I think we even had an influx of patients who we would see and be like, you know what, this would really be a very low chance. It would cost you, it was still a little more pricey at that time, like closer to $500. And people get mad that I wasn't going to do it. I'm like, no, this is a good thing. Like, you don't want this. Like, you don't want to test positive like this. And so that is a huge landmark of change. And regards to how people heard about genetic counseling. And anytime a celebrity or somebody famous talks about it, like Beyonce's dad had a BRCA mutation because he had male breast cancer, that like started an influx of some things. So it does really change. And I do feel like people come in more educated. People then talk about their tumor genetics. That's a whole nother, thing in the way that we're utilizing that for treatment. So, comparing your blood genetic testing, like what we call germline versus your tumor test results and how the genetics is different and such in patients. I usually ask them when I see them, tell me what you know about my field and like how you were sent here. And then I start from there. Because if they've done their homework, like I'd rather hear what they know and then fill in from there. Because if they have no idea who I am, then I'll explain who that I am and how I'm part of the team. But if they've done a bunch of homework, they're living this, right? They're living that cancer, or they're living this family history, and they may know more than they want than I do about their particular situation. And I want to hear about that first, right?
That's so crazy because 15 years ago, genetic counseling, I'm going to say, was hardly even a field. And now, like 15 years from now, it will probably be driving most of our medical decisions. That's an unbelievable change.
I know, and this is just my, big picture thinking, but I truly think there'll be a genetic counselor in every physician's office, and a conversation with every cancer patient will have some type of genetics. Whether a genetic counselor has that or not is a real picture. Like, I truly think that's going to happen. Of course, there are some cancers that we think are strongly sporadic or happen by chance, but we're even finding that certain lung cancers, and we've always said that lung cancer was just the smoking cancer, and there are some more, young, rare lung cancers that have genetic findings too. So I think even in just a breast surgeon's office, there'll be a genetic counselor, and her job will be to go in and even talk for 10 minutes. And if the patient doesn't want to talk about it, they don't need to. I don't know what you guys think about that. Do you think that is something that you would envision too?
We've sort of talked a lot about this. And I mean, I kind of I think that down the road, in breast especially, I don't know much about other cancers anymore, but in the breast arena, it seems like a lot of the treatments are becoming more and more conservative. We're trying to do more, less and less, right? The breast conserving therapy is now, making up the predominant portion of types of breast surgeries. And we're doing less and less. We're discouraging the contralateral prophylactic mastectomies unless there's something like, gene test that's present. So I feel like at some point, especially with the other adjuvant therapies that are coming out, treating a cancer may become less and less surgical. But I do think that as the genetic testing piece expands, we'll be able to detect more and more non-cancer people who are high risk. And so I don't think you can ever manage the high risk patient. I mean, unless you're doing serial examinations like we have or with imaging without a surgical intervention. So I just think that someday most of the surgeries that we do will be done in the high risk population, at least as a plastic surgeon. So, that's why I'm always very curious about, and in the cancer patient, it seems pretty straightforward. Patient has a cancer, they've got a team of doctors and they get plugged into this multimodality, group, and you're part of that. But I'm always fascinated about the person who's just chugging along, doesn't have a cancer, has maybe a small family history or no family history. These are people who are just going day to day. These are the people just listening to this podcast right now. I always wonder, how does that person sit here and think, oh man, I need to go get genetic testing? Or it's fascinating to me. And so I do think that ultimately, though, genetic testing will probably drive a large amount of high risk patients into our care.
Yeah, and seeing more unaffected. So I agree with you. And so just for a plug for my current job, we do have a high risk breast clinic. So there's a genetic counselor, lovely. Her name is Haley. She sees those types of patients that you just described that have family histories, are worried about breast cancer risk. And I've covered that clinic a couple times, and it runs very smoothly to where, she would see these patients, do a family history, talk through the pros and cons of genetic testing. If we can try to test other family members that have a diagnosis, then they see a physician as well to do an exam. They get imaging that day. So it's a nice broad, we run some risk models. So there is a slot for that right now. And I do feel like she is very busy. Her clinic is very busy. And will that type of clinic fill up like my clinic and other clinics? Because there's, I'm seeing unaffected patients who have family histories of GU cancers too. So it is happening. And I think that is the future of how we utilize these tests, and I always think back, and this will date me, and I don't know, you guys might not even know this. Do you guys ever seen the movie Gattaca?
Yeah,
Oh, gosh,
long
that
time
was a
ago.
long
So
time ago.
like, we had to watch that in grad school, and every time I think about that, I'm like, what if we all like have this test when we're born, and then we know all of our risk, and we're like sorted into groups? Like, how horrible, yet like kind of fascinating.
Oh, I remember that movie well,
I
actually.
do.
Yes.
God, who was that? Wasn't Joaquin Phoenix? I'm gonna have to look up.
No,
who was
Ethan
that
Hawke.
movie.
Ethan Hawke.
Yeah,
Ethan Hawke.
that is such a, oh my gosh. Yeah. Oh man, that's amazing. Yeah.
I know. Anybody on this podcast needs to watch that. I need to rewatch it because I think there's a lot of famous, not so famous at that time faces that you'll be like a little bit shocked by, but it's kind of crazy, you know, with CRISPR and other things coming. I'm like, are we going to like end up like this? And I don't know.
We're talking about that for the whole coronavirus piece. You know, are you IgG positive or not? You know, and then you're
geez.
sorted in two different groups. So that is like a scary world where DNA meets technology.
Well, and I think that, and it's always this ethical dilemma, right? And who decides where that line is, right? I mean, we all know that somebody already CRISPR'd a baby. Like that was a line that nobody in the U.S. wanted to cross, right? So,
Well, what is CRISPR?
Just so that so the people listening don't think that they got barbecued or something. Yeah, what is CRISPR? Tell us about that.
It's technology. You know, it's the new discussion, and you can Google it and look it up. But it's really trying to like help the progression of curing illnesses, and like the way that we would, you know, versus like we would used to use like vectors and other like ways to try to get in and like snip out the DNA basically that is wrong and fix it. And so I don't know. And also a piece of me, like I listened to a podcast about CRISPR talking about like, okay, so if we cure say like HIV, like what's the butterfly effect of that? Like what pandemic thing is going to happen? And then it's like, oh my gosh, we're living that right now. But you know, I just wonder if we start curing things, like what's the downstream effect of that? Like it's a good thing, like we want to cure these horrible conditions, but then I always also think like, is there some type of, I don't know, is the next thing's going to happen? Like, are we going to then make different mutations? And I don't know. So there's a whole lot of ethical. So this got down an ethical journey, but like the ethical of like, we can discover lots of things, but what is too much and where do we draw the line as to disclosing that type of information? And there's no right answer, right?
It's just like, you know, the stuff that we deal with like Facebook and Twitter. Like the technology is so quickly moving in DNA sequencing, and the ethics of it, the politics of it are not fast moving. In fact, we don't even know what the right answers are for all these questions that are coming up. I think you're so right. Like we've got all this great technology that we can use for good, but who knows what the downstream effects are.
See, this is where we get on the best podcast ever. We like to push the limits and really get to the point where now we've done the answers. Now we're at the unanswerable, which is what I love.
I was fascinated by, you were talking about how a lot of your research was on cardiac risk factors. So talk to us a little bit about that, because that's not something I know a lot about when it comes to genetic counseling.
I mean, it's been a bit, but I mean, why do we all get into the field that we get into? And of course, for me, it was driven, my dad died when I was in high school from a heart attack, and he had previous stuff. And for me, that drove a little bit of like, why did that happen? And then I learned about genetics, and I thought, well, shoot, do I need to worry about this? You know, yes, he smoked, and yes, he did this, but like he was a pretty fit young guy. So do I need to worry about that? And so that's, as we all decide what we do in life and take care of people and are in health fields, like what drives us. And that's how I ended up in getting into that. And but the tricky part is that piece of genetics is not as well understood as some of the other areas of cardiac. So more so like the muscular part, so meaning like cardiomyopathy and then your electrical rhythm issues. So that's the more well understood, even though it's still a bit further back than where we are with cancer. So there were less people on board when I got into it, meaning like less information, more unknown results. When you would do genetic testing panels, like it would be, I would get like 5 unknown results, which was like normal, versus like when we get them in cancer, it's like 1 every, 10 or 15 patients. So it's really, we were testing, and gosh, my cardiac colleagues are way better to talk about this than I am now. It's been forever. But really the biggest like issue that we need to test people in this country is cholesterol, because there is a condition called familial hypercholesterolemia, and it's as common as things like BRCA1 and 2. So like 1 in 500 people have this, and if you're a healthy person and you have high cholesterol, this can help us to know more about you and how to treat you and take care of you and such. So there's a big push to talk about that and to educate people about cholesterol. But it's really the young people that I hear about and the athletes who drop dead on the field. The immediate to me is like, what genetic issue? Did someone test them? Does somebody know to think about this? Like, that person was healthy and was a basketball star and they like dropped dead at 35. Like, holy moly. Somebody needs to like alert that family that they need to have a conversation, right? Or there were many times in this field, which was totally different from cancer. They would keep somebody on life support and have me come draw blood because they just had a sudden death event. And I'm like, that's a whole different discussion than like in cancer when usually it's a slower process to pass away. Talking to families like that is really intense and really challenges my counseling skills versus some of the things that I talk about, with cancer patients. So it's just different, but it's all the same genetics, right? So it runs in families. It can be dominant, but it's just different conditions. So it's all trained the same in regards to how we do things. It's just trying to specialize and understand the differences, right? So there's so much, as you guys know, going on in cancer. Once I took a step away from cardiac, so much changed already that I couldn't even, like I'm saying, comment that specifically because it's been so long. Like it's been a few years already.
Yeah, things change a lot very fast.
Yeah. Would you say breast cancer is probably the best understood from a genetic standpoint?
So really, genetic counseling started more so from a prenatal perspective. So really, it's most well understood from when people were getting testing when they were pregnant. So for like amnios and things, talking about like Down syndrome and cystic fibrosis. So really, cancer evolved after understanding prenatal genetics. So I guess maybe when you think of adult onset conditions, it's high up there for sure. I don't know, you're really testing my thinking in regards to, I would say yes, but prenatal is definitely first, and then pediatric and understanding childhood illnesses from the genetics perspective. Those were like the most populated genetic counseling areas to start with. That's how it was always well understood. Like my older colleagues started in those fields first and then moved to adult genetics. So it would have been cancer, then things like cardiac, then like neurogenetics. So cancer was definitely one of the first in the adult, so to say.
What are some takeaways that our audience should know about genetic screening? We've covered a lot of information, but what are some kind of real take-home points for people?
I think the one thing I would want people to think about, if this podcast has gotten you thinking about your family history and you're interested to get some more information, talk to your physician, like your family doctor, or if you have a cancer doctor, talk to them about referring you to a genetic counselor. There's no harm in getting some more information, right? And if genetic testing isn't right for you, the appointment isn't to force you to test. It's about getting educated about what it means, how that looks for you and for your family. So that would be the first thing that I would encourage individuals to do if they're interested. The other thing that I feel like is still out there, I just corrected this on a Facebook group the other day, is women do not think they can inherit female breast cancer risk from their father. That's absolutely untrue. You can get cancer risk from your dad or your mom's side. It's 50-50. And you can get male cancer from your mom's side, vice versa. So making sure you understand that point, and that cost for genetic testing is definitely decreased from what people think. There's just this myth out there that this whole process is so expensive. And genetic counseling is typically covered by insurance.
And Medicare covers it also?
Medicare actually is a large population that I see right now, and most of the time genetic testing for them is $0 to $100. And a lot of us, because of the way that Medicare works, we can't bill our actual appointment. So we've been trying to fight for getting access to billing so that we can help pay for us. Thankfully, all of the hospitals that we all work for find us valuable enough that we don't have to worry about that. But we would like to be able to bill so that we can justify our service. This is something actually I'll leave with too, that is, I actually saw a patient recently. So what's happening, there's a lot of Medicare fraud happening in patients. So what's happening is there are these like genetic testing companies that are sending kits directly to Medicare patients, and the physician or the genetic counselor's not ordering it, and the patient thinks that it was part of their healthcare. They're providing their saliva. They're sending this kit off. And that company is billing Medicare for genetic testing. And so what happens is I then see the patient want to try to order testing, and then I can't bill the testing because it's already been billed. And so for me to get valid company testing that I want to get done with a company I trust, the patient then has to pay out of pocket. So unfortunately, Medicare patients, this just happened a few weeks ago, and I think this company is taking advantage of Medicare patients, and this has been something that's been happening over the last year. So something else to be aware of as if we don't have enough drama to deal with.
But these are really good. It's good for people to understand the cost side of things. It's important to know that it's a myth that genetic counseling is so unaffordable, because that's something that I always kind of had in the back of my mind, that testing is so expensive. It's good to hear that it's come down as the technology has gotten a little bit more widespread.
Yeah, I mean, it was definitely very expensive when I first started in this field. And there are some tests that are not in the cancer world and some other things that are still expensive, but that's part of the discussion. And so then you can decide if that's something that you want to do, and to make sure you have full discussion before you opt out of doing a test. A lot of things that we're doing from the tumor genetics, that like looking at your actual cancer genetics, that may be still costly, and because that's newer. So like as newer technology and newer edge things happen in the pediatric world, some of the tests that we do there is very expensive because they're so new, and we're diagnosing very rare kids with very rare conditions. And so in order to do that, you have to do very unique type testing, which is harder to bill for. So take it 15 years ago, cancer genetic testing was new, right? And so that's where insurances were like, we're not covering this. And so now we're in a better zone for coverage for cancer genetic testing.
Where do you see the field going in 15, 20 years? I mean, is everyone going to have a little take-home genetic test and they'll get a little panel like out of Gattaca?
Like I already said, I do think they'll be working in all offices, so to say, but we can't produce as many genetic counselors that need to be needed at this point in time, right? So what we're doing at this current moment is adjusting our model. So it may be that we aren't counseling every patient. We're just counseling the positives or the ones that have unique results. And though the genetic testing is added automatically or something like that. And there's more, we're involved in more unique cases and such because it'll become more common, right? So usually your surgeon in the breast manner is like your lead person, right? So you get to your breast surgeon and they just say, okay, we're going to do all these testing, and genetic testing is a part of that. And then it gets dispersed as to what happens to them. I mean, I could see that. I mean, that could be part of it. And like you said, you take home a test and everybody does a genetic test. But I do think everyone will have some type of genetic testing in the next 10 years. I mean, I've had genetic testing. I think most people I know have had some sort of genetic testing just because it affects us in all different ways, whether it's for fun for you, if you want to do Ancestry or 23andMe, or if you're worried about things in your family because conditions can be so common. So I think genetics is the future, as we already know, and I know I'm biased in that matter, but it's definitely affecting everything. And we're learning to treat people differently based off their genetics. And that's only going to get more involved in regards to not only just cancer, but all the things that we can treat and take care of too.
Well, Lindsey, this was fantastic. As always, we learn a ton whenever we talk to you. We'd love to have you back on the podcast and get some follow-up on a lot of these things. I'm sure people will have a lot of questions, but let our folks know, how can they find you? What's the best way to get in touch with you if they have questions moving forward?
Yeah, and I don't know if you guys do questions and answer after, or just let them email you, but they email you and want to have questions for me, you can email me directly too. It's my first name, Lindsey Byrne, Byrne at osumc.edu. Yeah, and I know we threw a lot of genetic stuff around and didn't even have a chance to get into all the details. So I'd be happy to come back if there are particular topics that you're like, let's talk more about, or I'll connect you with somebody else who can dig into things like CRISPR that I am not really equipped to dig into much, other than the newest thing, and it's not really affecting necessarily cancer right now. So.
Well, there's one thing that we could pretty much bank on. By the time we talk again, which won't even be long, there'll probably be more genes on the profile that you guys are looking for. So thanks again, Lindsey. We appreciate it. We hope to get you back soon.
All right. Thanks, guys.
Thanks for listening.
We hope you found this episode helpful.
Want more info? Connect with us at mwbreast.com.
And go behind the scenes with us on Instagram at MWBreast. Thanks for tuning in.
And join us next week.